Hello, good morning. Hi, I'm Dr. Constance Teo, head of the SingHealth Duke NUS Head and Neck Center. It's nice to have all of you with us this morning. We have quite a few topics lined up today, and I hope it'll be helpful for all of you. And if you have any questions, do put it up in the Q&A button on the Zoom link below, and we'll try our very best to answer as many as we can. And there'll be a Q&A session at the end of it that all the three speakers will be addressing some of the common questions that all of you have. So today we have gathered quite a few of our experts from the different specialties from the Head and Neck Center. And to start the ball rolling, we have Dr. Siti Razia, who's a head and neck surgeon with the Department of ENT Head and Neck Surgery at SGH. So the topic that she's going to talk to all of us about is on neck lumps. And it's quite common, and I'm sure all of you had it at some point in time. And it may be kind of concerning, but it's very common when you have a flu. So when should you worry? And when is it okay to leave it alone? So I think I'll hand over the time to Dr. Siti now. Okay.
Thank you, Constance, for the kind introduction. I just want to make sure everybody can see the screen. So I think, as Dr. Teo has already mentioned, I think the topic is today is pretty common. Majority of us essentially have this issue or problem with lymph node swelling. And essentially, we always wonder whether it's something dangerous, whether it's something we need to look at, whether it's something that we need further investigation for. So I hope that at the end of this presentation, we'll have a better idea of what would essentially be something more sinister or more suspicious. So what exactly is the lymph node and what exactly are they useful for? So the lymph node actually makes up part of the lymphatic system. So if you look at that simple diagram on the left side of the slides, you can see that actually a lot of things make up the lymphatic system. So we have the lymph nodes, which are essentially in quite a number of places in the body. The neck, the armpit, the groin area, which we call the inguinal area. And they are actually bean-shaped structures, and they are interconnected with each other by lymph vessels. And the lymph nodes and the lymph vessels are like a network, and they are part of the immune system. The lymph vessels themselves actually carry fluid, which then circulate through this entire network, whereas the lymph node acts as a filter. So this filter will stop any foreign cells that is seen in the lymph fluid or is encountered in the lymph fluid. And the foreign cells can be any infection agent, whether it's fungus, bacteria, or virus. Or in the worst case scenario, they also filter cancer cells which are present in the body that is circulating through the body. So in that sense, actually the lymph nodes are quite important because they are one of the first defense mechanism against a very rapid spread of infection or cancer to the rest of the body. So essentially to me, it is like a notification system. It's like you having a notification that's saying, hey, my body is actually trying to defend itself from any serious infection, from any serious diseases, or from any serious infection. So it keeps you up and makes you aware so that you can monitor yourself in the next couple of days to see whether or not the situation improves, whether any infection goes away, or whether these lymph nodes continue to persist. So if you do get a lymph node, then should you immediately get alarmed? To be honest, a lymph node in the head and neck region is actually pretty common because we are very much exposed to a lot of bacteria and viruses, in our environment. Okay, and a lot of these essentially predisposes to us getting an infection, whether it's a ear infection, whether we have a common flu or the common cold, a dental infection, scalp infection, something as simple as a bad acne breakout, sinusitis, sore throat, very often actually leads to a lymph node swelling. Okay, so but what other causes would you suspect? If you don't have any of these ear, nose, throat infections, you've examined yourself, you don't feel that you have a sore throat, you don't have scalp infection, you have no acne, breakout, nothing, then what else can cause a spical lymph node or neck node inflammation or essentially a swelling? So we also consider systemic infection, for example, tuberculosis, HIV. This systemic infection or essentially widespread infection can also cause the lymph nodes to be swollen, not only in the neck, but also in the rest of the body. Autoimmune diseases such as SLE, like systemic lupus erythematosus and rheumatoid arthritis, are also things which can cause lymph nodes to be inflamed. Lymphoproliferative disorders, which are blood cell line diseases, which includes leukemia, lymphoma, multiple myeloma. These are essentially the blood cell line cancers. We also have the non-cancer types, for instance, like carcinoma disease. All these affect the blood cell line. This can also cause the lymph nodes to be inflamed. And of course, not forgetting the most worrisome of the lot, in addition to the blood cell line cancer, could be cancer from the head and neck region itself, and very rarely also they could be spread from other parts of the body. So how do you tell a cancerous lymph node from a non-cancerous lymph node? And can you actually tell the difference between the two? Generally, when we examine a lymph node, we pay particular attention to a few characteristics of the lymph node. The first is usually the size. Infective lymph nodes tend to be fluctuating in size, which means that during the infective episode, when it's at the start of the infection or at the peak of the infection, the lymph nodes tend to be pretty large. But once the infection is actually improving, once you've taken some treatment or antibiotics, the lymph nodes generally they generally resolve or recede. And basically, they go back to normal size usually after about 2 to 3 weeks. And the normal lymph node size is about 1.5 centimeters. So the ones that we actually worry about, which we think is possible that there may be a possibility that's not just simple infection, is those of those lymph nodes which are always big, which continues to grow. So these are the kinds that we actually would worry about, and we will have to do further investigations for. Now, the second thing that we look at is actually the age profile of the patient. So generally, if a young patient come to see me in the teens and adolescents, their immune system is a little bit more hypersensitive, hyperreactive. They're more likely to get an infective or inflamed lymph nodes from an infection. But in an older patient who does not present with any infection of any sort, there's no signs and symptoms suggestive in the past couple of weeks that he has had infection, and I'll be a little bit more concerned, a little bit more worried to look out and to explore for any possibility of any cancer or more sinister disease happening. Now, the consistency of the lymph node is also important. Cancer-related lymph nodes tend to be really hard, really firm, whereas soft lymph nodes tend to be mobile, and they tend to be soft lymph nodes which are mobile. They tend to be pretty harmless and pain. So basically, infective lymph nodes usually tend to be very painful right from the start, because you must imagine that actually the body is mounting a response and trying to fight against the infection and trying to prevent the infection from spreading. So because that the immune system is fighting against the infection, the lymph node is becoming inflamed, it's becoming swollen, there's a lot of reaction within it. So it's going to be very painful right from the start. But cancer-related lymph nodes, however, tend to be painless at the start. So until these cancer-related lymph nodes begin to grow into surrounding structures or begin to grow into surrounding nerves where they then cause pain, or this cancer-related lymph node becomes so big that there's also a superimposed infection within it, and then they start to be a little bit more painful. Now, besides that, you can also try and elucidate perhaps or think back about important symptoms that you may have that may be associated with cancerous lymph nodes. So, like I've mentioned before, a lymph node that is lasting longer than a few weeks is something that we will always worry about. A lymph node that gets progressively larger, it doesn't seem to improve, it doesn't seem to get better, is also something that we would be worrying about. There are also other changes in the head and neck region, such as a voice change that is persistent, there's heavy or noisy breathing, one-sided blocked nose, difficulty swallowing, there's blood, the saliva, the mucus, there's blocked ear, there's ulcer that's not healing. All of these, together with the presence of a lymph node, will be a little bit more suggestive or a little bit more worrisome. Is there persistent neck or throat pain that is not improved with painkillers? there's unexplained weight loss, meaning there's no dieting done, there's no exercise done, and yet the weight loss is significant, or there's unexplained or persistent fever, there is no signs of infection elsewhere, but you keep getting a fever. And the fever keeps returning despite taking Panadol or despite taking treatment, the fever keeps returning. This is when we start looking for, hey, is there a possibility that this is not just an infection alone? It is something more dangerous than that. So there are also risk factors essentially in our social behavior that can also increases the risk of having cancer. I think smoking and heavy drinking is something that is have always been flagged up as something that is significant as a risk factor for any sort of cancer in the body, to be honest, not just the head and neck region alone. But this is something that we need to essentially drive the point. Smoking and heavy drinking is definitely a significant risk factor and should and we strongly encourage people to stop this practice. Immunocompromised states, for instance, a patient who is on long-term steroids for whatever, perhaps for any autoimmune diseases, or a transplant patient who's on long-term steroids, they generally have a higher tendency of developing cancer in various parts of the body. Betel nut chewing. I think betel nut chewing is no longer a very common practice in Singapore, but essentially in many countries around Asia, betel nut chewing is still quite common. And you can see that essentially the patient or the picture here, where the teeth is all yellow and the teeth is all eroded, that's actually quite a common picture for someone who uses the betel nut quite often, who chews betel nut quite often. And that actually increases the risk of having oral cavity cancer, for instance, cancer of the cheek, inner lining of the cheek, cancer of the tongue, cancer of the palate. Dentures which are poorly fitted and cause repeated ulcers, essentially when the dentures keeps moving and it keeps cutting into the tongue and it keeps cutting at the same location, or it keeps abrading the gum at the same location, these tend to actually cause repeated ulcers. And the repeated ulcers can eventually mutate and become essentially cancerous in the future. So, and a strong family history. When we say strong family history, usually what we look at is the number of people in the family that have the particular sort of cancer. And usually 2 or more family members can be considered a rather strong family history for in terms of a family history for cancer. So what do the doctors do when you actually present? What do we do as doctors when you present to us with a swollen lymph node in the neck? First and foremost, we always examine the lymph node because it's important to us actually to look at the characteristic of the lymph node, to feel where it is, to know exactly what it feels like, to see whether it's stuck to the underlying structures, whether the skin is smooth above it. And then we examine the rest of the neck as well to see whether there are any other growths and masses that you may have missed. Maybe you were essentially just distracted by that lymph node, but some other growth is present elsewhere. So we will examine the lymph node and the rest of the neck. At the same time, what we examine is the entire ear, nose, and throat. So this is an examination of the oral cavity, an examination of the mouth. Okay, we examine the ear. Okay, and then we would put in the scope. If you go to most of the ENT specialists, or you go into the essentially the head and neck surgeons, most of us would just put in a scope, a nasal endoscope, to have a look and see whether there's a problem with the nose, there's a problem at the back of the nose, there's a problem deep-seated within the throat. Okay, that's actually causing this particular infection if we don't see anything in the mouth on examining the mouth or examining the ear. Now, depending on the clinical suspicion, if we see that there's actually an infection somewhere, then usually antibiotics and then monitoring for response may actually be the first line. And most of us would actually choose this as the first line, just a trial of antibiotics, perhaps for about 2 to 3 weeks, and then we call you back to see whether or not this responds to the lymph node, this responds to the infection. And if everything responds and everything clears, then a lot of us will be satisfied and pretty confident that it's actually infective in nature. However, okay, after examining and there's literally no signs of infection, not even when we have asked the patient about the history, there is no signs of pain or sore throat, there's no signs of a flu, there's no history of a fever, then maybe our suspicion from cancer is a little bit higher. And this is when the scan will be ordered, and usually a CT or an MRI scan or a PET scan is done to evaluate the lymph node and any associated growths in the head and neck region or elsewhere. A biopsy may also be done, either of the lymph node or any abnormal growth that we found during the examination in cases of suspected cancer. So most of the time in the head and neck area or in the ENT area, basically when we do a lymph node biopsy or we do a lung biopsy, it could sometimes be in the form of a needle aspiration, just a needle that we insert into that particular lump or that particular lymph node, draw a little bit of tissue, we send for testing. That should most of the time be sufficient. Unfortunately, if we are unable to do that, then we would go ahead with an open biopsy, which you see on the picture on the right. So what if you don't seek medical attention for the swollen lymph nodes? Is there any harm? So the most important thing I need to drive is that the good news is that majority of lymph node swelling is actually infection related. So they should resolve on their own even without treatment once the infection clears. A lot of us may have a flu and then our flu is just there for a couple of days, then if the flu slowly goes away. Whatever lymph node that we have should actually go away on their own as well once the infection gets better, once our flu clears. But the ones where the lymph nodes do not go away and yet you don't get a medical opinion for this, then there is a danger of missing cancer and a danger of further worsening of the disease. So this is where you pay attention if the lymph nodes are persisting. So how do I examine the lymph nodes in my neck? So I do try to see whether I could educate patients that come and see me on how to examine and monitor any lymph nodes that they have. Generally, these are the instructions that we give. We will ask you to use your fingertips when feeling for the lymph nodes. And you move the movement and you move essentially in a gentle circular motion, okay, in various parts of your neck. So you can actually just be systematic. Be systematic so that you don't miss certain locations in certain parts of the neck. And if you look at the picture or the diagram on the right, you can see that this is where the common nodes are located in the neck. So essentially we feel beneath the chin, we work up the chin, we work up to the front of the ear, we feel behind the ear, we work to the back of the neck, underneath this, just beneath the hairline. We go down to the back of the neck, and then we follow the collarbone. And then after that, we can actually feel along the muscle. So when you're examining on that side of the neck, usually there are a lot of muscles actually in our neck area. So in order to relax the muscles in the neck, we usually advise you to just tilt your head a little bit to the side you're examining. Okay, so that you can actually dip your fingertips at the edge, behind the edge of the muscle, so that you can feel for any possibility of lymph nodes or essentially growths around the area. Okay, and always compare the two sides. Okay, and when you compare the two sides, then you can look for differences. Is that, hey, is there something here and there's nothing there? You know, because most of the time our neck is made to be symmetrical. Okay, so if there's some asymmetry or there's a lump that you feel on one side, a little bit of a fullness that you feel on the one side, that's usually something that's a little bit abnormal and should be looked at. So that's the end of the presentation. It's a simple presentation. I just wanted to bring an introduction. Always, if in doubt, seek medical help early. Okay, so this is the end of my presentation. I think we'll be taking questions at the end of the entire session.
Thank you very much, Siti. So going on to our second speaker is Dr. Katisa. She is a senior consultant with the National Cancer Center and one of our very instrumental personnel in setting up one of our first proton centers. So today she's going to talk about proton therapy, which is something very new, you know, and maybe some of you have heard about it and would like to know more. So I'll hand the stage over to Katisa. Thank you.
Yeah, good morning, everyone. And thank you, Constance, for the introduction. So today, welcome to the talk, and I'm excited to share with you the exciting advancement in cancer treatment, particularly focusing on proton therapy today. So this is the outline of my sharing today. And first, let's understand what exactly is proton therapy. So proton therapy is a type of radiation therapy that uses positively charged particles, that is protons, to treat cancer cells. So radiation therapy is often used to treat some head and neck cancers alongside other usual treatments such as surgery or chemotherapy. So radiation utilizes high energy waves or particles such as proton or X-rays to target cancer cells. So this high energy radiation, it will penetrate the cells and directly damage the DNA that is within the cells. So when the DNA is damaged inside the cells, it will disrupt its ability to grow and divide. So this DNA damage will then trigger a series of events that will eventually lead to cell death. So because cancer cells divide more rapidly than normal cells, they are more vulnerable to DNA damage. This means that radiation therapy can effectively kill cancer cells while at the same time minimize harm to the surrounding healthy tissue that is also exposed to the radiation. So radiation therapy is a type of local treatment. So unlike systemic treatments such as chemotherapy, where the drug travel through the entire body, radiation therapy is only directed and stay focused to the site of the cancer. So this makes it particularly effective for treating localized tumor because it focuses on a specific area of the body where the cancer is located. So because radiation is a local treatment, the side effects are also localized and related to the area that is being treated. So for example, radiation to the head and neck region might cause mouth ulcers, whereas radiation to the chest region could cause a lung irritation. So there are several types of radiation that is used in treatment, but the two most common ones that are used are X-rays and protons. So X-rays are most widely used form of radiation therapy. They are known to be highly effective and it has been standard treatment for many years. So proton therapy, on the other hand, are fairly new and we used positively charged particles, as I mentioned earlier. So radiation is a traditional form of, X-ray is a traditional form of radiation therapy. So when X-rays are used to treat cancers, they pass through the body, targeting the tumor that is located usually at the center and delivering radiation not only to the tumor, but also to the healthy tissues that is located surrounding the tumor before and after the tumor. So proton therapy works slightly differently. They are positively charged, and they also have a very unique property that allows protons to release most of the high energy right at the tumor site, and therefore leaving very minimal radiation affecting the healthy tissues that is behind the tumor. So this is a video that will illustrate the two differences between X-ray treatment. So we have a patient with a tumor. More often than not, the tumor is located in the center of the patient's body. And with that, we give a margin, and that's our target to treat. And when we direct radiation X-ray to the tumor, although the cancer can be treated with high dose of radiation, the healthy tissues are exposed as well. So with proton therapy, we utilizes proton pencil beam technique, which is a very advanced form of proton therapy delivery system. It uses a narrow and focused beam of protons to deliver radiation dot by dot, layer by layer, to paint the tumor in a three-dimensional fashion. So this is particularly useful if you want to treat complex or irregular shaped tumors. And you could see that because the unique properties of proton, it is the high dose region are very much tightly confined to where the tumor is, with very few exit doors beyond the tumor. So the head and neck regions is home to many critical structures, including the brain, spinal cord, salivary glands, swallowing muscles, vocal cord, and the tongue. So when we give radiation to the head and neck region, it is possible to affect these healthy tissues or organs, leading to side effects. So radiation therapy, while it is highly effective, it can also bring various side effects. And these side effects sometimes can be quite severe, and they can differ greatly depending on the area of treatment. So during treatment, it is not uncommon that patients will experience pain from eating due to ulcers in the mouth, no taste, swallowing problems, dry mouth, and as a result of that, weight loss and poor nutrition. So in the long term, side effects such as dry mouth and difficulty in swallowing or scarring and stiffness are fairly common for head and neck patients. So they can, in some patients, impact their daily life. making simple pleasures such as enjoying taste and enjoying food difficult. And we know that when we hear from our patients, these very powerful stories that from our head and neck patients do highlight the reality of some of the side effects and impact on a patient's quality of life. So proton therapy has a huge potential in the treatment of head and neck cancers because of the location. So in simpler terms, imagine a proton beam as a precision tool that delivers a powerful punch exactly where it's needed, and at the same time, it spares the surrounding healthy tissues. So these precisions allow us to maintain the cancer cure rates and at the same time reduces long-term and short-term side effects, including getting secondary cancer from unnecessary radiation, and at the same time also improve the long-term quality of life for our patients. So the unique property of proton makes it a very desirable tool in many clinical situations. So in Singapore, we are very much guided by the Ministry of Health, which has provided a list of approved indications for the use of proton beam therapy in treatment. So in head and neck cancers, proton therapy offers a major advantage, and this precision is particularly important, and it offers a particular advantage, especially when we are treating tumors that are situated deep in the head and neck region, such as when we are treating patients with sinuses that's quite near to the brain, nasal cavity, nasopharynx and oropharynx region, and in young patients when you're treating the salivary gland region as well. So these are the tumor sites that have a particular advantage when we are using proton therapy to treat them. So the precision of proton therapy will result in lesser radiation dose to salivary glands, mouth, and swallowing muscles mainly. And because of the reduction in this unnecessary radiation, we will be looking at the potential of reducing side effects and complications, such as lesser patient with dry mouth and difficulty in swallowing or any long-term damage to the vision or hearing. So these are just plan comparison, just two different plans that between proton therapy and a standard X-ray treatment of this particular case. So in this particular treatment, we are focusing the radiation to the cancer site, which is on the right side, one side of the neck, and comparing proton radiation and X-ray radiation, we are able to spare unnecessary radiation to the other side of the neck and the mouth as well, compared to the standard radiation dose. So we expect that if the patient is treated with proton therapy, this patient is less likely to develop things like mouth ulcers during treatment, dryness of the mouth, swallowing problems in the short term and in the long term as well. So this is just another comparison as well. So when we're treating patients with tumor that's in the middle of the neck, including both sides of the lymph nodes of the neck, then comparing a proton therapy plant and a standard radiation plant, we are able to see that the calculated dose to the mouth region is greatly reduced with proton therapy, as well as when we look at the whole plan comprehensively, the dose to the swallowing muscles, to the lymph nodes, swallowing muscles, to the vocal cords, and to the salivary glands are much reduced as well. So when we are able to minimize unnecessary injury to these healthy tissues, proton therapy could improve the quality of life for such patients undergoing such a morbid treatment. So it is a significant advancement compared to the traditional form of radiation, and proton is able to offer an effective and also a safer treatment options. So as we gain more experience when we treat more cancer patients with proton therapy, since the opening of the proton therapy machine last year, we observed that our group of patients do indeed display low rate of side effects. And also very pleasingly, most of our patients actually were able to maintain their weight during the course of radiation. So when we chart their weight from the beginning of the treatment and weekly throughout the radiation weeks, and then shortly after radiation, we do know that most patients do maintain their weight, and even if they lose weight, they lose very minimal amount of weight as well. In fact, there are some patients who, to the contrary to our expectation, put on weight during the radiation because of the good tolerability of proton therapy. So at the current moment, there are more than 100 centers in the world that provide proton therapy facilities. They're in operation, and more is coming up. So in Singapore, we are very fortunate to have 3 proton centers, with the Proton Therapy Center in the National Cancer Center, Singapore being the largest facility of them all. And this is located in our new, not so new now, we are 1 year old, National Cancer Center building. The Goh Cheng Liang Proton Therapy Center is located at basement 3. So this is a massive building that offers a one-stop multidisciplinary integrated oncology service, from diagnosis to treatment to follow-up. So we are equipped with the latest technology to provide comprehensive care to our cancer patients. So I would like to share this video just to highlight that in our National Cancer Center, we have 4 treatment units with full rotating gantry to allow us to deliver proton therapy to our patients. We also have 1, what we call the fixed beam room, where the proton therapy beam is actually fixed at a particular direction, and this is mainly used for research. So during the proton therapy, the patient is actually positioned in a very high precision robotic couch. So the treatment room, each treatment room is also equipped with advanced imaging system that allows us to precisely position the patient to allow us to deliver the beam accurately. So we also have the full rotating system. That allows us, so this rotating system actually rotates the nozzle of the treatment where the proton beam comes out around the patient 360 degrees. So this gives us great degree of freedom and flexibility to allow the proton beam to be delivered from virtually any angle to target the tumors with pinpoint accuracy to a spot size of as small as 2 millimeters across. So in our center, we use a pencil beam proton therapy, and we started the treatment of our first patient on the 27th of June last year. And this patient also happened to be a head and neck patient. And at the current moment, we have 3 out of 4 gantries that are in operation, and we treat approximately about 30-ish to 40 patients a day. And till date, we have treated more than 180 patients. So we do treat pediatrics patients as well, alongside our adult patients. So there are some considerations in selecting patients for proton therapy. It is a localized treatment, so it is not suitable for all types of cancers. So patients would be assessed by a multidisciplinary team regarding the suitability of proton therapy. If a patient has very widespread disease, then proton therapy being a local treatment would not be the ideal treatment of choice. As you can see, the radiation beam from pencil beam delivery has to deliver the dose dot by dot, layer by layer. So we do require a patient to be able to lie still for the around 30 minutes of beam delivery. So reproducibility is also another factor that we consider. If there's some reason preventing a patient from lying still, or there's a lot of movement during treatment, then proton may not be the ideal modality as well. There are some technical issues that make proton therapy less ideal. So for example, if a patient has a pacemaker, then giving proton therapy, we may have serious consideration, because the proton therapy may have a chance of causing malfunction of the pacemaker, especially if a patient is highly dependent on the function of the pacemaker. So when the patient comes to our center, and the patient will be assessed if proton therapy is the ideal treatment for the patient. So the first step is always an initial consultation with your radiation oncologist. So during the first visit, we will discuss your diagnosis, we'll review your medical history, and we will also determine if proton therapy is the right option for you. So if that is so, then next we will move to the preparation phase. So for head and neck patients, we create a customized immobilization shell to keep you still during the time of radiation. A dental review with the dentist is also conducted to address any potential dental issues that may affect radiation therapy. So following that, we perform a CT simulation. So this is a CT scan wearing a shell. So these detailed scans will help us to map out the exact location, shape, and size of the tumor. So using this data, our radiation team then develops a personalized treatment plan that aims to precisely target the tumor while at the same time spare the healthy tissues surrounding the tumor. So this is a complex process, complicated process. Often we have to do multiple reviews to ensure that we choose and we come up with the most optimal plan for our patients. So finally, when the plan is finalized, the treatment will begin. So essentially, proton therapy sessions are typically delivered over several weeks. It is an outpatient procedure and daily from Monday to Friday. So on public holidays and weekends, we are closed. And each session, depending on the complexity of the plan, probably would take about 20 to 45 minutes lying down. So each session is quite quick and quite painful. So the number of times that a patient has to undergo radiation depends pretty much on the patient's condition, on the type of the cancer they have, and also on the stage of the cancer. So in National Cancer Center, we have a dedicated proton therapy team that from the doctors, the radiation oncologists, including the behind-the-scenes heroes, the dosimetries and the medical physicists, and the radiation therapies that plans and deliver the radiation, and our nurses that manages our patients for their side effects during the time of radiation as well. So in conclusion, proton therapy represents a significant advancement in cancer treatment, offering precise targeting of tumors and fewer side effects. It is a promising option for selected cancer patients. So in National Cancer Center Singapore, we are committed to provide a cutting-edge proton therapy service to improve the outcomes of our patients. If you or your loved one are considering cancer treatment options, so I encourage you to feel free to reach out to us to find out more. And with that, I end my sharing. Thank you.
Thank you very much, Katisa. So going on to our last speaker, we have Ms. Alberta Loh. So in tumors of the head and neck area, very often our patients will worry about how they can get back to health because they have problem. They worry about their speech, about their swallowing, and we work very closely with besides doctors, we work very closely with our allied health team in the head and neck center to make sure that our patient actually get back on track. And a lot of them actually do get better. So I think I'll hand the stage over to Ms. Alberta Loh, our senior speech therapist from Singapore General Hospital. Thank you, Alberta.
Thanks, Constance. Hi, everyone. Good morning. My name is Alberta, and I'm a speech therapist at Singapore General Hospital. And a large part of my work actually involves working with individuals with cancer, specifically in the head and neck region. And it's my great privilege to be able to share with you today more about my profession, speech therapy, but also our role in the rehab journey for individuals who are undergoing head and neck cancer treatment. So just an overview of speech therapy. So it's actually quite a broad discipline with many, many areas, but the main ones that we are concerned about in head and neck cancer treatment are swallowing and also communication, namely speech and voice. So normal swallowing involves the ability to transport food and drink from the mouth through the throat into the stomach in a safe and efficient manner. Voice is the ability of our vocal folds to produce sound or the sound of our unique voice. And speech is the ability to articulate or to pronounce words and phrases clearly so that, we can communicate with others and they can understand what we are saying. So although we rely quite heavily on these abilities to function well on a day-to-day basis, we often do not pause to think about it, or we may even take some of these functions for granted. However, a person who has head and neck cancer may struggle very much in these areas. So I think you've already seen this diagram this morning. So these are just some of the key areas that we might be concerned about. So cancer could arise in any of these areas and could potentially affect a person's swallowing and communication. So it could be found in the lips, the tongue, the upper and lower jaw, the nasal cavity, and also the throat area. So the top part of the throat area, the back of the nose, is called the nasopharynx. And just below that is the oropharynx. So that's the part that you look at when you actually see into somebody's mouth. And the lowest part of the throat is the hypopharynx. So tumors could sometimes appear there. And cancer can also arise in the larynx or the voice box, where our vocal cords are. So as mentioned by our previous speakers, the treatment options for head and neck cancer can include surgery, where the tumor is resected. It can also include radiotherapy and chemotherapy. So a person could be recommended just one or a combination of these treatments. So for example, for a tongue cancer, the recommended treatment may be surgery first, followed by a course of radiotherapy. But for somebody who has a cancer in the hypopharynx, then the main treatment might just be radiotherapy only. In any case, the course of treatment for the cancer can have an impact on the speech, the voice, and the swallowing abilities of a person. As today's sharing is fairly short, we won't be able to go through every type of head and neck cancer and the specific recovery process. But to give you an idea of the kind of work that we do, I'm going to share like a case example which represents a typical patient that we might encounter in hospital. So just imagine this. We have a patient who presents with a tongue ulcer for about 2 months and it hasn't gotten any better. So the patient went to a GP who then recommended that he should seek the opinion of a specialist. So the specialist performed a biopsy and diagnosed this ulcer as tongue cancer, or more specifically, squamous cell carcinoma, or SCC. After some further workup and discussion with other medical professionals, the recommended treatment for this patient is surgery for the tongue, followed by radiotherapy. So at this point, the patient may have their first meeting with a speech therapist. The speech therapist can take some time to do a pre-op assessment. So this is getting an idea of the patient's current speech and swallowing abilities, as well as do some pre-op counseling. So this actually involves us sharing some information about what the patient can expect immediately post-op, but also further into the future with regard to their function. This meeting also gives the patient an opportunity to ask questions and to clarify doubts that they might have. And it can actually be quite assuring to hear from us that we will be seeing them again after surgery and will continue to be involved in their care. So then the patient is admitted into the hospital for surgery. And for this tongue cancer, the surgery involves removal of the cancer as well as some extra margins. So this is just extra space around the tumor to ensure a bit more complete removal of the cancer cells. So if the cancer, the ulcer, is quite small, then the surgeon may be able to just close the wound by stitching it together. But if the defect is fairly large, then an extra piece of tissue might be needed to patch the defect. So this extra piece of tissue is often taken from another part of the body, and this is called flap reconstruction. So most of the time, it might be taken from like the forearm, which is like this picture here, or it might also be taken from the thigh. So the picture on this slide shows an example of a tongue with a flap. Are you able to identify the flap? So if you think that it's on this side, the yellow arrow, then yes, you're right. That's the example of the flap. So this is another example of one of our patients with a tongue flap on his right. So at this point, a question that you might ask is, what kind of impact will this have on a person's communication and swallowing function? So let's start with speech. So the tongue is arguably the most important articulator in the oral cavity. If the tongue loses part of its shape and its muscle, it will not be as flexible or strong as it usually is. If there is a flap on the tongue, it could also cause it to become like quite bulky and a little bit heavy, and also cause it to be a bit slower when it moves. As such, the tongue may not easily curve or flatten, and so certain sounds may sound a little bit muffled or imprecise. So some of the common sounds that our patients have difficulty with are the S sound, the SH sound, and the L sound, because these sounds really require you to move your tongue in very precise manner. So to demonstrate this, why don't you read the following sentences out loud with me? Okay, and as you are reading, I just want you to pay attention to how your tongue is moving. Think about all the movements it's doing, all the positions that it's going to, and also think about the speed at which it's moving. Okay, so let's read this. Sally sells seashells. Larry likes lollipops. Karen is making a cake. Tim is putting on a hat. So you realize as you were reading that the tongue actually makes very precise, very intentional movements, and every position actually creates a different sound. And it does so actually very quickly in order for us to speak fast. So as you can imagine, if the tongue was less mobile, less flexible, then some of these sounds will sound quite unclear and the articulation will be imprecise. And you may actually have to speak slower in order to be understood. So to help our patients, we would engage them in some rehabilitation for speech. So we usually work on articulation or pronunciation, and this involves, teaching the person how to position their tongue, their jaw, and their teeth in order to create a clearer sound. So we might use like a mouth model, like the two pictures here on the right, where we show you exactly where to move the tongue to make a certain sound. And after the patient has learned just a single sound, we will practice it over and over and over again in articulation drills. After that, we would practice this sound in syllables, in words, in phrases, and eventually in conversation. And as you can imagine, right, it will take a long time and it takes a lot of hard work, and the patient really has to, be quite hardworking in practicing it at home. We also teach speech strategies for clearer speech, such as, intentionally speaking more slowly or trying to over-articulate every word. In some cases, though, speech may no longer be a viable option for communication. So, for example, if the patient undergoes a very major surgery that requires the removal of, say, more than 75% of the tongue, then in those cases, we may work with the patient to explore other modes of communication. So one example is training them to use a text-to-speech app where the person can type what they want to say, and then the application helps them to read it out. In terms of eating and drinking, the experience will be quite different as well. If the tongue is no longer as strong or flexible as before, the person will have difficulty moving food around the mouth for chewing. So, when we want to chew something, our tongue actually has to bring the food to the sides of the mouth for chewing. And then when we are ready to swallow, the tongue helps us to gather all the food together to the center and then propels all the food backwards for us to swallow it through the throat. So the person may also then have some problems controlling or manipulating the food and water in the mouth. And this could result in having a lot of food and water left in the mouth. So this is what we call oral residue. Sometimes some of our patients, because they can't really control the water, it just flows back really quickly, and that can also result in increased choking risk. So they may be coughing more often or choking during the meal. So, now if you happen to have a cup of water next to you or even your morning coffee, why don't you try it? So take a sip of your drink and think about what your tongue is doing, how well your tongue controls the water, and only when you are ready to swallow, you will realize that your tongue just sweeps back and allows you to swallow the water in one go. Almost no residue is left behind in the mouth. And most likely, you were able to swallow the water without choking, I hope. But our patient in this case example will likely have some problems doing it so effortlessly, he may need to actually think very carefully about drinking the water before he does it. And in the rehab process also, he might need some extra time, to really learn the process of swallowing again. Okay, so as part of our swallowing intervention, the speech therapist will properly assess the movement and the strength of the oral structures, as well as the individual's swallowing abilities. So sometimes we recommend thickened fluids. So I'm not sure if you are familiar with this thickener, which could make the water a bit safer or easier to swallow. So it's just like a powder that we can add to drinks like water, coffee, tea, and it will make the fluid thicker. So as you can see in the pictures below, right, the water from left to right shows increasing level of thickness. So the thicker the fluid, sometimes it might help to be easier to control, reduce the choking risk, and just make the whole process a little bit safer for the patient. Besides looking at the water and the fluids, we also recommend a safe diet for the patient to consume. So at the start, just after post-surgery, we may start with something a little bit simpler like puree or blended food. And over time, as the patient gets better, we may increase the difficulty to something like a minced diet or a chopped diet. And, it's great if the patient will eventually be able to reach like a normal diet, like what you and I eat. As part of our assessment, there is also some problem solving and creative thinking. So during sessions, we usually get our patients to try different things to see what works best, what helps them to swallow better or more safely. So for example, some of our patients, they do best when they do spoon feeding. So they drink water with a spoon instead of a cup. But some others may actually do better with a straw instead of a spoon. Sometimes we kind of use this instrument here, which is a syringe with an extension tube. So this could be beneficial for some of our patients with some difficulty controlling the water. So we just want to kind of get the fluids further back into the throat for easier swallowing. So this may be suitable for some of our patients. Sometimes, some of our patients also need a bit more comprehensive swallowing assessments. So we can send our patients for a scope. So like this one on the left, a tiny camera is inserted through the nose so that we can visualize the back of the throat into the larynx, the voice box. And so we can actually see what's happening when they swallow. So the other example is to do a swallow X-ray study like the video here, okay, on the right. So during both of these assessments, the patients will be trying to swallow different things, and then we will observe how their muscles are moving and how safe their swallowing is. And doing a X-ray or a scope like this can actually help to guide our recommendations a little bit more accurately and also help us to plan our rehab for this patient. So part of the rehabilitation also involves doing exercises, and also sometimes we might teach some swallowing strategies. So in our exercises that we teach, the aim is actually to improve on the strength, the range, and the stamina of the oral and pharyngeal structures. So this could include things like tongue stretches, like the picture on the left, jaw stretches, like the middle picture, and also some swallowing exercises. So one example is the effortful swallow, where basically you try to swallow your saliva, but you use as much strength as you can to swallow it. So that just helps to activate the throat muscles a bit more. So usually these exercises, we will encourage our patients to do them daily, and we might even recommend a frequency if they can follow. So for example, like jaw stretching, we may tell the patient, why don't you try 7 reps of 7 seconds, 7 times a day, something that could be easy to remember, but of course, it has to be something practical for them. We may also introduce some swallow strategies. So swallowing strategies involve some intentional movement or action that would help the individual to swallow better. So an example is a chin tuck position. So basically you look down during the swallow. Sometimes this might be safer for the patient. or even a head turn, like the picture on the top right. So getting the patient to look to one side, in this picture is the right side, so that when he's swallowing, he's actually using more of the left side muscles, which, in this case could be stronger. So like I mentioned, this could make the swallowing more safe or more efficient. But, which strategy to use really depends on how the patient presents and what specific difficulties they might have. Some of our patients may also be suitable to have a prosthesis made to help them swallow better. So working with our colleagues from the National Dental Centre, sometimes we would work with them to design or make intraoral prosthesis to help to improve the patient's swallowing and speech. So an example here, right, is the palatal augmentation prosthesis. So it's made for a patient who has tongue surgery. It's kind of like a denture that you will attach onto the upper teeth, and it helps to lower the height of the roof of the mouth. So in the picture, you can see on the right, you're comparing the two. The one with the purple prosthesis in, you can tell that the tongue actually does not need to reach so high to reach the top of the mouth. So in this case, sometimes it helps to improve the oral manipulation, the swallowing, and also speech, because the tongue actually touches the top of the mouth for some of the sounds that we have to make. Okay, so as mentioned before, many of our patients actually undergo radiotherapy as part of their treatment. And for some, this may be the only treatment that they receive. So this involves receiving radiation to kill the cancer left in the body. But, as Dr. Khatisa said, radiotherapy does come with short-term and long-term side effects that has a huge impact on swallowing and communication. So some of the short-term side effects that the patient may experience during and just shortly after radiotherapy would include things like mucositis, where there are painful ulcers, pain on swallowing, dry mouth, so the tongue may appear, just very dry, very cracked, changes in the saliva consistency. So saliva may also become very thick and sticky, contributing to the feeling that the mouth is just very dry. Some of our patients also report changes in taste. So either food and drink just taste very bland, or food and drink suddenly have a weird taste. Sometimes they may even say that when they drink water, it tastes very metallic. So that could be a possibility. Going through radiotherapy is also very tiring for the patient. So they would usually present quite lethargic and with poor appetite. And sometimes also this could cause a loss of weight because they're just not eating enough. So after the course of radiotherapy, which usually is about like 6 to 7 weeks, some of these short-term side effects do improve. And we also reassure our patients that, sometimes it just takes some time for them to get better. However, there are some long-term side effects that could set in months or even many years after they're done with treatment. So one example is fibrosis, where the muscles of the mouth and the neck become very stiff and very tight. So the muscles are no longer as flexible and they cannot move as well. So, you might see some people with really stiff neck, they can't really turn their neck, the tongue doesn't move so well anymore. So this is also related to trismus. So trismus, like in this picture shows, is a jaw opening difficulty because the muscles of the jaw are also very tight. So this patient here on the right actually has very severe trismus. So you can see the gap between his teeth. This patient will have a lot of difficulty trying to feed himself with a spoon because the spoon will not be able to really enter the mouth easily. So another long-term side effect is actually a dry mouth. So unfortunately, this may not fully go away after radiotherapy is done, but sometimes we will prescribe or we will recommend them to use certain mouthwashes that have a moisturizing quality, or to also, just continue to drink water regularly throughout the day, or even to carry along a mouth spray. A more complex complication of radiotherapy treatment is cranial nerve neuropathy. So the nerves may gradually get damaged, and this could lead to the weakening of the muscles. So if you see in this video, we have somebody with a cranial nerve impairment for the tongue. So the right side of the tongue looks smaller than the left side, meaning his right, so it's on our left. And you can see that it's like tremoring a little bit. So we call this fasciculations. And that is some evidence that the cranial nerve is already being damaged. So as you can imagine, I've talked quite a bit about cancer treatment. It's actually really quite tough, and dealing with the after effects can be quite difficult for many individuals. So as speech therapists, we play a role in encouraging our patients to keep going and also to maintain their functions of swallowing and speech by doing two things, which is to continue swallowing and to do exercises. So during treatment, even when our patients may have reduced appetite or find it quite difficult to eat and drink due to pain, we still encourage them to keep swallowing or to keep eating and drinking a little bit if they can, so that they're moving the muscles. And we also try to encourage them to do some exercises so they keep active in the neck area and the mouth area. So research has shown that continually doing swallowing and doing exercises actually yield the best outcomes in terms of eating and drinking in future. So part of our work is actually finding ways to make this possible while also motivating and encouraging our patients along in their journey. So I've covered quite a bit of content today, but if I could just summarize, speech therapists are there every step of the way. So we journey with the patient from the time of the diagnosis to the time they receive their treatment and also beyond. And at every point, we try to address the patient's concerns about their swallowing and communication and try to maximize their function as much as possible. So helping them to eat and drink more normal textures and helping them to communicate effectively with their family, loved ones, and friends. And above all, we are always thinking about their quality of life. So, having a head and neck cancer can have a huge impact on a person's life, not just their physical functions, but also things like self-esteem, sense of self-worth, their goals, their motivation in life. So we, as well as the medical team that we work with, we need to constantly think about the impact on the individual and consider how we can help them physically, emotionally, and also socially. So to end, I just want to share that, as speech therapists, we are always keen to help people who have communication and swallowing difficulties. And this is actually not limited to just patients with head and neck cancer, but also other medical issues like dementia, Parkinson's disease, for example. So if you are an individual who is facing some difficulty with communication or swallowing, or a loved one who has these difficulties, you can reach out for help. Just inform your doctor and get a referral to speech therapy, and we'll be really happy to assist. And with that, I just conclude my sharing, and I thank you for your kind attention. Thank you.
Thank you very much, Alberta. So as you can see, there's actually a lot of things that we can do. So I think some of our patients come late because they're worried, about, how they're worried to find out that whether they have cancer or not. And very often it's not. So I think if there's something persistent, do, come and let us see. Because even if the worst case scenario that you have something, is much easier for rehab, the chance of cure and everything is much better. And in the Head and Neck Center at SingHealth, we actually have a very good team of what we call allied health professionals, our speech therapists, our dietitians, our psychologists, our nursing team, and we have a special clinic that look after all our patients that need to undergo major surgeries, for all these conditions. So unfortunately, we don't have enough time to introduce everyone in the team to you guys today, but today we have Alberta. So I think we are going on to the Q&A session, and we have received quite a number of questions. We will try and answer as best as we can. So I think I'll pass to Dr. Siti first to answer some of the questions that we have from all of you. Yep.
Hi guys. Okay, thank you. To be honest, I don't remember what was the question that was selected for. Oh, okay, there we go. Okay, sorry. So is there a high incidence of mouth cancer from biting repeatedly at the same spot or tongue or the inner side of the cheek, be it because of denture when at sleep, and can we prevent biting repeatedly during sleep? I think I picked this question because there are a few other questions that were similar to this. I think what we need to drive in is that usually what we are talking about when we look at possibilities of cancer developing in the oral cavity or in the tongue, in the mouth, the buccal mucosa, the lining of the cheeks, is that repeated trauma. So when we say repeated trauma means that it's repeated open wounds that happen from abrasion, biting, or essentially the dentures not fitting and just keeps abrading or irritating the same spot over and over again. Okay, those have a higher tendency of eventually becoming, and if they are untreated and the problem is not addressed, those have a higher tendency of turning into a cancerous change, becoming or having some cancerous change in the future. So the truth of the matter is how you differentiate a cancerous ulcer versus a non-cancerous ulcer is that cancerous ulcer tends to be deeper. They tend to be essentially bigger. Okay, whereas the ulcers that we get on and off as part and parcel of, like, maybe we don't drink enough water, maybe we're a little bit sick, we're having a flu, those kind of ulcers that we have usually are small, they are superficial, it's just the surface lining only has an ulcer. Whereas the cancerous kind of ulcer is a little bit more, it's definitely significant. You can actually feel that it's gone beyond the actual surface layers. It's much deeper into the tissues. Okay, and essentially it is a wider area than you would expect, okay, to the normal ulcers that we get. Okay, and it doesn't seem to go away no matter how much treatment you put on it, whether you put an ointment, you put a gargle, or you take antibiotics, you went to see the dentist, they gave you a whole set of medication, it doesn't go away. No matter what you do, it doesn't go away after 2 to 3 weeks, it doesn't go away after a month. Those are the kind of ulcers we start to be concerned, hey, something is happening there. Okay, so it could be dentures, it could be recurrent biting habits, whatever it is, okay, the ulcer result, which are cancerous in nature, tend to be similar in appearance, similar in characteristics. Okay, so the only thing is that if you do have an ill-fitting denture, so I would really, really advise you, please go to the dentist and get it fitted properly. Okay, and get all those adhesive device and dental device that allows, or the dental adhesive device to allow it to stick properly even when you eat and drink, so it doesn't cause further problems or abrasions. Change your denture regularly. As we age, essentially our mandible is essentially the lower part of the jaw, our maxilla, which is the upper part of the jaw, we tend to recede as we grow older. Everything in our body recede, we become smaller. It's the natural process of life. Yeah, so our dentures won't fit. A denture that fitted you 5 years ago will not fit you 5 years down the road. So you need to make sure you see the dentist regularly and change the denture if it no longer fits and if it's dropping off when you eat. Now, the other thing is that what do you do to prevent biting repeatedly during sleep? We have tooth guards. The good news is we have tooth guards. So these tooth guards can actually go to the dentist to fit it particular to your teeth or to your anatomy, to your particular mouth, so that essentially you can prevent the teeth from biting into the buccal mucosa, into the cheek lining when you're sleeping at night. If you have a tongue bite or you have a teeth biting habit when you sleep at night. Yeah, teeth grinding habit when you sleep at night. So there are tooth guards available, so don't worry. Okay, so I hope that answers this question. Now, can we go on to the next one? Okay, so how do you treat tumor or cyst in salivary gland which is seated very deep inside, and can we do a biopsy? Okay, so this is actually similar to a third question which I selected. So I wanted to answer both questions at the same time. Debbie, do you think you could flash the third question? Yep. So, no, sorry, the fourth question. Could you just flash the fourth question? Yeah, yes. Okay. So basically now this is a question about salivary gland tumors. So the second question and the fourth questions are pretty similar. So it's about salivary gland tumors. Now, salivary gland tumors do happen. And they can sometimes happen without a family history or family predisposition. It can just happen. Okay, and we do have many salivary glands. Okay, we have 6 major salivary glands, which is essentially in the parotid, the submandibular, and the sublingual. And then we have many minor salivary glands, which keeps our oral cavity, our swallowing tube, our mouth all moist and nice. Now, so the truth of the salivary gland cancers or salivary gland tumors is that 80% we always use a essentially basically a rule maybe a rule of thumb, most of the tumors in the parotid gland, which is at the sides of the face in front of the ear, okay, majority of them are benign, okay, and then maybe 60% of the ones in the submandibular glands, which are at the end, at the bottom of our jaw here, maybe 60% of them benign, and then the one underneath the tongue here, which is sublingual, essentially maybe about 40% of them are benign. So once you have, what we do usually is that when you have a lump in any of these regions, okay, the first thing we do is that we do a proper examination. Okay, that essentially means taking a look into your oral cavity, okay, and then we take a look at essentially the duct as well, whether the duct, when we press on the duct, if there's any blood, there's any pus coming out, okay. We take a look at the gland itself. How big is the gland? Okay. How big is that tumor? Whether it's a firm tumor, whether there are overlying skin changes, whether it's stuck to the underlying muscle. And then we go on to examine the rest of the neck. Okay, when we examine the rest of the neck, we are feeling for any possible lymph nodes. So if the tumor happened in solitude, which means it's just that tumor alone, it's that growth alone, okay, and there's no lymph nodes that we can feel, okay, then we try, then essentially we will do investigations, okay, which are related to that particular salivary gland. So most of the investigations that we do are in the form of a scan, okay, as well as a biopsy. Now, the first question, the first question regarding to the salivary gland was essentially whether or not we can do a biopsy and how we do a biopsy. So most of the time, what we can do when we do a biopsy essentially is that we can do the biopsy even in the clinic. If we can actually feel the growth, we can feel the tumor. We just put in a needle, okay, into that particular growth. Put in a needle into that particular growth. Okay, with or without local anesthetic, it's usually not that painful. It's similar to a vaccination or to an injection, and then we draw a bit of tissue, we send for testing. Okay, majority of the time, that is sufficient. Okay, now, only in those deep-seated tumor, meaning that I can feel, for instance, that there is definitely a fullness in this particular one side compared to the other side, but I don't feel a discrete growth or mass, then what I usually do is that I will send the patient for a scan first. Okay, so this particular scan can be the form of a CT scan, okay, or sometimes if the patient is not suitable for a CT scan, or then maybe I will send it for an ultrasound. Now, based on what I find on the CT scan or the ultrasound, I can also arrange for an ultrasound guided biopsy, okay, which is essentially means that we just use the ultrasound, we locate where that growth is, and then after that, we inject a needle into that particular location to draw a bit of tissue and send for testing. Only in instances where the needle test is not sufficient to give us an answer of what sort of growth this is, okay, then it becomes an open biopsy has to be considered. So this open biopsy has to be a conversation between you and the ENT specialist or head and neck specialist, okay, on what sort of open biopsy has to be considered. So there are two types of open biopsy. One type of open biopsy removes the whole tumor altogether. Okay, when we remove the whole tumor altogether, okay, with a part of the gland, we send it for a complete testing, which we call final histology, which gives us a better idea of what sort of group we are dealing with. This is the situation where where the needle test does not give us an answer of what particular growth we are dealing with. Okay. Now, the second type of an open biopsy is an incisional biopsy. Now, the incisional biopsy means that we just make a small cut above the growth and we take a little bit of the tissue and we send for testing in order to give us an idea, okay, of what particular growth we are dealing with, okay? So which one is appropriate for you depends on the particular condition we are dealing with. So it should always be a discussion between you and the surgeon that you are seeing, okay? But both methods are possible, which is the needle test versus the open biopsy type. Okay, now if you have a gland tumor, salivary gland tumor that has associated lymph node, okay, associated neck lump, then this becomes even more suspicious for us. Okay, this becomes something that we will essentially be concerned about with regards to cancer. Is it a cancer that is growing within the salivary gland that has metastasized or spread to the surrounding lymph nodes? Okay, so in these sort of instances, again, the evaluation will be done of the salivary gland itself, and the evaluation also may have to be done of the lymph node as well. Okay, and if you are already developing some Because when you say there are numbness or essentially there are nerve-related changes, okay, then there will also be increased concern, because usually benign growths, non-cancerous growth, they do not usually invade, or they do not usually press, or they do not usually cause nerve changes. When you start to develop nerve changes, for instance, numbness, difficulty with speech because the tongue movement is irregular, okay, because of a growth around the neck or around the jaw, okay, there is essentially retractable pain that is not improved with painkillers. Okay, all of these are essentially very important sign to us to indicate, okay, that, okay, perhaps this is not just a benign growth that we are dealing with, this is something else, because more things, or essentially more signs, are associated with this particular growth now. Okay, so those will be ones where we will expedite all the treatment, all the investigations, okay, so that we can plan for a treatment earlier rather than later. Now, so what are the implications if surgery needs to be done for submandibular gland, which is around this part of the face, okay, which is beneath the jaw, beneath the mandible, okay? So for this particular location, there are three important nerves, okay? The first nerve is essentially the nerve to the angle of the lip. Second one is essentially the nerve to the tongue, which supplies the sensation of the tongue. The third one is again the nerve to the tongue, which supplies the movement of the tongue. So any of these three nerves can be affected, okay, during a submandibular gland surgery. And this is a common thing you would hear if you spoke to your primary surgeon, okay? They will also explain to you the possibility and the risk of this happening. So it's the nerve to the lip is essentially injured during this particular procedure. You will notice that when you smile, okay, now you don't have a symmetrical smile. So when you smile, one side of the lip will actually droop. And why is it troublesome or difficult? It's because when you eat and drink, okay, you will notice that some part of the food particles or essentially liquids can actually drool because you can't really control, okay, the angle of your lip or the tip of the lip. Okay, so that's actually quite troublesome. Not only to say, and besides that, it's also quite disfiguring, because when you smile, people notice, hey, why your lip like that? And one side saying it. Okay, so that's a possibility. Now, the second one essentially is the nerve to the tongue, which is for sensation. So what happens is that you'll feel that that part of the tongue is always numb. It's a little bit uncomfortable. It feels as if sometimes there's a little bit of pins and needles, you know, like ends going through that part of the tongue, that half of the tongue. Occasionally, what happens is because you can't feel that tongue properly, you may have recurrent biting into that side of the tongue. So that's a possibility. So the third one, I was telling you the nerve to essentially to the movement of the tongue. If essentially the nerve to the movement of the tongue is affected, unfortunately, because the tongue is so important as I talk, my tongue is actually moving up and down, bobbing left and right, you know, it's coordinating left side and right side. So unfortunately, when one part of the tongue is unable to move as well as the other side, becomes uncoordinated. So this results in my swallowing being affected. Essentially, it results in my speech not being clear. Okay, this is when Alberta have to come in and start some physiotherapy in order to improve both the function of the swallowing and the speech. Okay, so that's essentially the risk associated with the surgery. But implication, okay, a lot of the patients who come to see with salivary gland disorders, and they ask me whether or not they will have less saliva after a salivary gland surgery. No, the answer is no. I've mentioned before, we have 6 major salivary glands in the head and neck region, and we have minor salivary glands everywhere, thousands of them. Okay, if you take out one, it does not affect your salivary gland production. Your mouth will still be moist. Okay, so it should be a problem. Okay, I think, I hope I've answered both those questions. I think, Debbie, there's one last question for me. Yes, okay, so small lump on your gum. Okay, so basically a small lump on the gum that goes away with a course of antibiotics is usually quite satisfying or quite comforting, okay? Because if you have treatment done and treatment actually gets rid of the lump, then usually it's not cancerous in nature, it's probably effective in nature. Okay, but the lump is just reduced, but it's still there. So what I generally advise is that sometimes, okay, for gums as well as teeth, what we see is actually what we see with the naked eye is just superficial. Okay, we don't know whether there's any deep-seated infection. Very often, dental infection can be pretty deep-seated, which means that the dental root, the root canal, okay, the bone of the gum, the bone of the mandible, or the bone of the gum where the teeth sits, essentially may also be infected. So you may have taken antibiotics which just treat the superficial infection, okay, but we have not gotten to the root of that infection, where the infection is actually deep-seated within the teeth, or deep-seated within the gum, or deep-seated within the bone. So that usually requires a very thorough cleaning by the dentist, a very thorough washout, a very thorough look at the tooth itself. Okay, so basically, whenever you have this and essentially taking the antibiotics, gone away, but it's not completely clear. So it's always a good idea to essentially go to the dentist, or even if you see a private dentist or a dentist in a polyclinic, okay, to have them look at your teeth appropriately, and to have them look at the gum appropriately, so that essentially you know whether or not the treatment that you've gotten is adequate, and whether you need further scaling or cleaning, deep-seated cleaning of that particular location. Now, if you've done these, okay, you've done the cleaning, the scaling, you've looked at the dentist, you've done all that is necessary, okay, and your gum the infection is completely cleared, even the deep-seated component cleared, and essentially you still have a lump, okay, then this will be something that we will have to look at even more closely, perhaps some kind of a CT scan or MRI scan, to make sure there is no growth within the bone or the gum itself. Okay, so I hope that answers the question.
Yeah, thank you very much. I think we're going to Dr. Katisa. Yeah.
Yeah, I think just a couple of questions. So what are the side effects from these radiation treatments? So because this is a local treatment, so the side effects are really dependent on the area that received the radiation. But generally for patients that had radiation to the head and neck region, it's not uncommon during the time of radiation for them to have a little bit of disturbance or taste, change in the taste, a bit of dry mouth, and ulcers or pain, and skin reactions, a bit like sunburn reactions at the neck region, are also quite fairly common side effects during the treatment. In the long term, also again, depending on the recovery and depending on the area of treatment, some patients can have a bit of scarring or stiffness around the neck region in terms of their jaw opening or their neck movement. Some patients can get difficulty in swallowing. Dry mouth as well is also fairly common, and sometimes a bit of change in the way they perceive taste. Can go on to the next question. So what is the success rate of proton therapy in removing cancer? Is it able to kill all cancer cells that are being radiated? Will some cancer cells be missed from being radiated? So the success rates are actually highly dependent on the stage of the tumor and also the types of the cancer. Some cancer cells, some types are generally more sensitive to treatment than others. There are different types of cancer cells, and some are not so sensitive to radiation, and therefore the success rate are lower. So apart from that, stage plays an important factor as well. Obviously, the higher the stage where the tumor is more extensive, then the success rate sort of like fall with treatment. So generally within the area of treatment, the proton therapy has very good chance of eliminating the cancer cells within the area of treatment. But however, the cancer cells are not all the same. They are not clones, basically. So within the group of cancer cells, within the tumor, they can have subgroups of cancer cells that are more resistant or more naughty, if you say. So they may not respond in the same way as the rest of the cancer cells within the tumor. So unfortunately, even after we are able to deliver very good dose of radiation to the entire tumor region, there will be some patients that unfortunately the cancer cells are just more resistant, and they may develop recurrence within the area of treatment. Sometimes we do see cancer cells that actually they have already sort of spread at the time of diagnosis, and they may hide in a site that is further away from the cancer cells, and those areas are not treated. So when given time, they may relapse as well. So, but if you're able to tell where exactly the cancer cells is, and we are able to deliver a good dose of radiation, generally the success rates are quite favorable. Can go on to the next question.
Oh, okay. Yes. So I saw this question in the chat, and I thought I'll just address some parts of it. So yeah, sorry about your late aunt. Yeah, so we actually do see patients, all kinds of patients, and this includes also palliative patients who may be diagnosed with something that that would cause them to approach the end of life. So sometimes we see these patients, and we also do help them with their swallowing, being able to eat and drink all the way to the end. Yeah. So besides this, I also just want to mention that we see all kinds of patients, with also sudden medical issues like a stroke. Maybe they have been in ICU for a while, had surgery and deconditioned, and we also do help these patients who may have some swallowing difficulties that are acquired. So just to mention, if you have a loved one, you're not sure whether or not they have swallowing difficulties, some of the things that we might look out for are coughing or choking during a meal, maybe some shortness of breath during the meal or after the meal. And sometimes we also notice like a voice change, meaning that, at the start of the meal, the voice sounds quite clear, but as they drink and eat some more, you notice that they sound a little bit gurgly or a little bit wet. So those are all signs that we can look out for. And if you do suspect that your loved one is struggling with swallowing safely or efficiently, then you can definitely look for a doctor and then get a referral to speech therapy. Yeah. Okay. So I had another question about the pathway for allied health professionals. So the answer is yes, we actually do have a pathway. So when patients see doctors and the treatment recommended, the surgery, radiotherapy, these patients will actually be seen by the speech therapists, the dietitians, psychologists, and physiotherapists before their surgeries. So what we do is we do some pre-op counseling where we give a bit more information about what to expect during treatment. We also give them some information about what they can expect after the surgery and beyond. So, in a year's time, will they be able to eat and drink? What will they be able to eat and drink? And things like that. So another good thing about it is that, we see them face to face. So they recognize us, and then, when we see them again in the inpatient wards and in future, they recognize us, and there is some assurance there that we will be following up with them, and we will be helping them in these areas. So yes, the answer is that we do have a pathway to make sure that we see all these patients. Okay. Is there another question? Okay, yeah. So I had one more question related specifically to swallowing. So this person has difficulty swallowing. Sometimes it's a pill, so a capsule. Sometimes it's some food that gets stuck in the throat. So then should you seek help? So I would say that actually when it comes to pill swallowing, it's actually quite different and quite difficult for some people. So, some of us, we are actually normal, meaning that we eat and drink very well. But when it comes to swallowing a pill, that presents like a specific challenge. And that can actually be quite normal for some of us. But if I could give you a tip, if you have difficulty swallowing pills, definitely go one at a time. What you can do is try to position it, in the middle of the tongue, take a sip of water, and just before you're about to swallow, you kind of count in your head 1, 2, 3, and at the time that you're ready, just sweep the tongue back, and sometimes that helps to get the pill down in one swift action. Yeah, so we do actually work with some of our patients who have specific issues with pill swallowing. So I would say that it's actually not very alarming if it's only related to like large pills, but you're eating and you're drinking still okay. You don't really choke during meals. You can eat your meal quite effortlessly. Then it's likely just related to just pill swallowing, which is quite normal. But if you are not sure and it's happening also on food and it's really affecting your social life, like you find it difficult to go out to eat, it's taking very long to finish the meal, then I would say yes, definitely come and see us, and we can help you problem solve and see how we can help you with that. Yeah.
Hi, thank you very much. So there's a lot of questions. I hope that we have managed to answer most of the burning questions that all of you have. Unfortunately, we can't answer all of them. But I think the take-home point is that a lot of other symptoms, lump in neck, is very common. So there's no need to panic if, let's say, you're having a flu or you accidentally bite on the area, and you can wait about 2-3 weeks to see how it goes. But if it doesn't, please do get a consultation. If you're not sure, you can always see your primary care physician with your GP or the polyclinic. And they can actually assess and see who's the appropriate specialist, to actually refer to. And if it's something that's really urgent, they're worried about, we do have expedited protocols to make sure that our patients get seen as soon as possible. So so that's one way. If you have further questions and we are unable to answer today, do check in with your primary care physician, and they will be able to refer you to appropriate doctors. Yeah, so I hope all of you enjoyed the session today and hope that it's been helpful. I think Dr. Katisa has something to say. Yes, if all the panelists, if you have anything to convey to our attendees here, please do. Yeah, Katisa.
Yeah, sorry, I just wanted to make a comment on the costing. I see a lot of interest in questions about costing. Unfortunately, the cost of proton therapy, just make a quick comment, proton therapy at the current moment is not subsidized yet. So a small part of the cost may be able to claim from MediShield Life, depending on indications as well. We can't give a general estimate of the costing because it also depends on the indications, the diagnosis, as well as the number of treatments that we are planning for patients as well. So that's why we can't really comment very much. So each individual patient, if they have different fractions or different treatment or regimen, the costing can be different. And the costing also different from diagnosis for each diagnosis. Most of the patients, a huge component of the payment will be out of pocket, either cash or if you have private insurance that enable coverage for proton therapy. So that needs to be inquired with your insurance provider. Thank you.
Okay. Thank you very much. Thank you for joining us today, everyone.